So our next panel is a great panel, and my dear friend Chris Purnell, anyway, I'll go on and on about Chris, but I'm going to ask her to head it off, and we've got a great group of people that are on it. We've got Dr. Gloria Bachmann from Rutgers Global from Women. We've got Ruthie Byrne, Sandy Cayo, Mary Pat Christie. Sharon is with us. I'm really so proud. Petros from Rutgers, and Chris Purnell, Akash, and the great Erin Zerbo from Rutgers Center of Excellence. So the whole focus of today was to focus on trauma. And this is a really painful topic because, as we all know, and we heard from the Cardinal to Lieutenant Governor to Reverend Sharpton, Governor Christie, our women, Reverend Bartley, Van Jones, our legislators, the importance of systems of housing, systems of healthcare, systems of training, systems of employment. But part of this is, and I think we heard time and time again, is that you've got to deal with this trauma. I remember anecdotally when I was working with a woman, I'm never going to be a good mother. I'll always be an addict. I'll never hold down a job. And it's those tapes, those tales we tell ourselves. And my friend Mary Pat is on, and so I'm so grateful. So this sounds maybe too simple, but I'd like to ask, and we got the great Dan Lombardo on from whose camera is like, I see half your head, Dan. VOA, there you go. Maybe you should go back to the half of the head. No, I would like my dear friend Chris Purnell to tell us what is trauma.
Definitely. Thank you, Governor, for that. And I was able to catch some of the conference earlier today. So I just first want to center on how important this dialogue is to be able to elevate and to amplify the lived experiences and the role of systems and removing barriers, removing health inequities that prevent people from achieving health equity, health justice, and racial justice. So if we were to ask ourselves, what is trauma? I want to start being a public health physician and being in this role at University Hospital as Chief Strategic Integration Health Equity Officer. I want to define health equity because understanding trauma through the lens of what we would hope everyone would be able to achieve then informs the processes, the systems, the actions, the culture, the shift that needs to happen in order to appropriately care for persons. So APHA, the American Public Health Association, defines health equity as the ability for everyone to achieve their highest level of health. Right. So it's a very aspirational and inclusive goal. So health inequities form when you have unjust and avoidable, emphasizing avoidable barriers that prevent the realization of that. And what are those barriers? Those barriers often rest at the level of structural determinants or the level of what some term social determinants of health. And what are social determinants of health? They are those factors, those conditions, place-based conditions, where you are born, where you live, where you age, where you work, where you play, the culture, the norms, the physical environment, the emotional environment, the social environment. So you could very well say that trauma is, or childhood experiences, adverse childhood experiences, or toxic stress is a social determinant of health. It is a condition, it is a factor, it is a determinant of the ability of a person to achieve a health outcome. And it's important that how we each understand, define, or interpret trauma does have some unique experiences around it. So trauma is an event, a series of events, a set of circumstances experienced by an individual that is physically, that is emotionally harmful or life-threatening. So I, as a person, determine whether that event was physically or emotionally harmful or life-threatening. And that trauma could have been experienced in my youth, right? Those adverse childhood events, living in a neighborhood with epidemic portions of community violence, living in a neighborhood where there is decades worth of economic disinvestment, neighborhood disrepair, less access to high quality schools, a crumbling built environment, living in a neighborhood that is over policed, living in a neighborhood where your neighbors are justice involved families. All of that creates a level of toxicity that individuals who determine those experiences to be harmful or life-threatening then develop maladaptive behaviors, oftentimes coping mechanisms to treat the trauma that they are experiencing, right? Those behaviors are treating or in response to, are cultivated by cues in the environment. So then that leads us to say, well, if there is this baseline level of toxic stress or trauma or adverse childhood events that can have maladaptive behaviors, so it can have impact on your mental and behavioral health, impact on your physical health, then what are the outcomes associated with that? So we see what mass incarceration has revealed, what white supremacy and systems of racism have revealed. It is that trauma before an event, trauma during an event, and trauma outside of that event is cumulative. So if we use something very specific here and say trauma before incarceration versus trauma during incarceration versus trauma on re-entry, it's cumulative. And if that trauma isn't being processed, if that trauma isn't being ameliorated, if that trauma isn't being mitigated, it becomes overwhelming. And the person beneath the weight of the trauma crumbles or it's underdeveloped.
And we heard that today from Craig. And
yes.
He talked about, people that were in the jail system. The Stanford experiment was supposed to be 2 weeks long. They stopped it after 3 days because people were crumbling. The first person crumbles and everybody thinks, well, maybe they're not up to the task. The second person, and then by the time the third person comes, they figure, hey, we've got to stop this experiment because people are crumbling. And maybe it's not that they're unable or they don't have grit. Maybe
it's not an individual failing. It's not an individual factor. It is a system, a set of circumstances that predispose a negative or traumatic response.
And so, Chris, if I can just go to Petros, Doctor, you're a psychiatrist and chair of psychiatry. When you hear what Chris says about trauma growing up, whether it's the chaos of the street or for women in Ed and Mahan, I'm going to call Gloria, sexual violence, domestic abuse. And one of the things that, and I'm grateful to the legislative leadership, to the governor, to make sure, and as Dan Lombardo does every day with VOA and we have to produce longitudinal results. But one of the things that I see is, to go to Chris's point, that if that trauma isn't addressed, we can almost do everything right. But so what do we do about that trauma, Doctor?
Yeah, thanks, Jim, and thanks, Chris, for this absolutely wonderful summary of how we see trauma in 2021. I just want to add one more thing to it, that for a long time we have been locked to the idea of a single traumatic event, that something terrible happens to you, you witness some death, or you get raped, or something horrible happens, and from then on you have this post-traumatic stress disorder. Thankfully, these days we have expanded that concept, and we very often now talk about complex trauma that can be exactly the cumulative trauma that Chris described, and it can be as horrific, or quite a lot of times more horrific, than the single event traumatic experience. So from a diagnostic perspective, from the way that we understand trauma, we have moved the needle to something that is far more real and helpful in the way of how we treat the trauma. Now, to get to your question, Jim, about what to do about it. The major blocks of psychiatry are still here to help. Medications for people who need it, and counseling and psychotherapy, which is also something that can be tremendously helpful to patients who suffer from this, especially for this complex trauma. Some patients will need medication. We do have some safe and effective ways of.
Doc, can I ask a more fundamental question, just for I count myself among the ignorant? So what is it, so that if we have trauma or Jim has trauma, what is the goal of, whether Mary Pat Christie working with a supportive addicted woman, or Ruth, what is our goal? What are we supposed to be doing with that trauma? Sorry to ask such a basic question, but what is the goal of all of us on this call?
The way that I would formulate it in my head is twofold. On one hand is relief of symptoms right here, right now. You're depressed, you're anxious, you cannot sleep, you cannot perform in your daily activities. How to address these aspects so that you can be functional? And the second part, which of course goes in tandem with the first one, is to go a little deeper and find out what happened, how did this trauma really develop, and try to get to the more root causes of the problem. That takes some skill and takes some effort, but both of those aspects need to be addressed. And
So go ahead. It's the relief of the symptoms, and it's digging deeper.
Correct.
And I'm going to call upon Mary Pat. I was really impressed that she put her hand up, which I've never been able to figure out how to do in 4,000 Zoom calls. But could you just talk a little bit? I'm going to call upon Mary Pat. So when you say dig deeper, the goal is, and excuse my vernacular, is the goal is to get it out and put it on the table? Is the goal to make sense of it? Is the goal to surrender? Or is that an individual decision? So I guess what I'm saying is, I understand relief of symptoms. That's pretty straightforward. But when you go deeper to what end? I apologize for my simplistic questions or simple questions.
So is that for me?
No, that was for Petros.
Okay.
Oh no!
He's got the fancy medical
I'm not
school.
the expert, but I have thoughts on it. But hey,
I have thoughts about it myself as well. But I'm going to pass this one, if I may, to Erin Zerbo, because she really knows about these things very, very well in terms of the isolation of affect that we do see with trauma, and how we can possibly address this.
Dan, this is what academics do.
No, there's a particular reason why I'm passing this today to Erin Zerbo, because our school decided to honor Erin Zerbo today with the Humanitarian Award of the Year, which is the highest award that the medical school bestows on any of the faculty. So I am so proud of her, and I just want to put her on the spot for that.
Thank you, Doctor.
Thank you,
Erin.
Petros, I appreciate it.
And congratulations.
Thank you. So this is terrible, but can we like narrow it a little? What is
Okay,
exactly
sure.
you want me to address?
So, no, I appreciate that. So doctor said two things, trauma. One is relief of symptoms, and the second was to dig deeper. And so my question is as not as to the first, but as to the second, dig deeper to what end? To do what? To get it out on the table, and then to do what with it? To make sense of it, to acceptance, whatever. I'm sorry.
No, and I think this is actually the key thing when you're working with somebody that's traumatized. So I think this is the most important point you can make about trauma, which is you want to be very aware if you're working with somebody in a session. It's basically this idea of opening it up. So the way I think about a traumatic memory is that it's stored neurologically in your brain differently from a regular memory. So when you have a traumatic memory, your brain, people will talk about it almost like a flashbulb memory. Like you have a memory, think of like where you were when you heard about 9/11, for example. Everybody can usually go back and like picture what that was like. And it's like that when something traumatic happens, your brain is like, oh my God, something really important is going on. And so it literally will record the thoughts you're having, the smells, the sensations, the sights, the feelings, and everything feels very kind of surreal, and oftentimes is either sped up or slowed down. Like just things are kind of weird. And what's interesting about a traumatic memory, it's stored in this congealed way where if you touch it and trigger it, it will come to life in its full colors. And so that's what a flashback is. And that's what happens when people get triggered. So it's basically these memories that are kind of like congealed and more like vivid color than other ones. And they can be hidden a lot of the time. But if you like scratch the surface and they pop out, all of a sudden the person is flooded with all this emotion. So when you're working with somebody, and I see Iris nodding, so I know I'm on the right track because she is the trauma guru and she should speak right after me. But the idea is when you're working with people with trauma, you kind of want to dance around everything except the actual trauma. You want it to be organic and they have to be
Wait, can you say that again? What you just said, a little slower.
Sorry, you want to kind of dance around everything except the actual trauma. Like if for a classic thing is when I was trained as a psychiatrist, you take an abuse history and they would say I'm sexually abused. And you would be like, oh, I don't want to open the wound, but by who and for how long? And just give me some basic, it's like, now you've already opened the wound, right? If you're even asking who abused you, like now you've already started to go into that. So as in 2021, as we've realized all these things are triggers for people. And so you want to be real delicate around the actual traumatic stuff. And in the beginning stages of working with someone, all you're working on is like day-to-day support, grounding, resourcing, like teaching them breathing, meditation, etc. And if you are going to open up and actually talk about a trauma, you need to be very aware of what time you have because you have to close it back down before the end of the session. The big mistake.
Can I go back to my simple question? So what is the goal of this process?
Right. So the ultimate goal is to get that traumatic memory to no longer be congealed and have all that power where when it's tapped into it like blossoms like that, you want to reintegrate it into the historical narrative of the person's brain, right? Like just kind of make it like a normal memory. But to do that, you have to, psychotherapy is actually not super effective. It will be more things like EMDR, cognitive processing therapy, these like trauma specific therapies. And they're very like, there's a lot of training involved, a lot of like manual and kind of instruction, because you basically want to really slowly get back into the memory. But at the same time, you've already given the person those tools about how to do breathing. Because if you open up a traumatic memory and they leave your office feeling anxious, you didn't do anything to help. You just like reinforced that this traumatic memory causes anxiety. So it's like you want to work through the memory, but that's like later stages in the treatment. In the beginning of the treatment, you're getting the connection, building rapport, giving them resources, and you have to be kind of ready to go into the traumatic material when you have enough time.
And are you trying to make sense of it, or is it acceptance, or is it? I mean, so I'm beginning to understand, but is the ultimate? So you sort of deal with that, for lack of a better word, toxicity or potency. But is the ultimate goal? I mean, I'm listening to what Chris said on the outset. So I grew up and there was chaos on my street, chaos in my home, chaos in my relationship. What is the psychological goal? I mean, maybe goal is the wrong word, but how does this journey make sense?
Yeah, that's such an important question because the problem with these traumatic memories is that people have misbeliefs attached to them. So if you were really little and your parents were physically abusive towards you, you internalized that you were a bad kid. And so at the time when your parents were physically abusing you, you had thoughts in your head like, I'm so bad, I wish I weren't here, like my parents hate me. And with these memories congealed, if you have that memory in your head, that automatic thought is going to spring back with it. And so you just have this dark, heavy feeling about these memories because they're reactivating beliefs and emotions, many of which were just activated because you were a child. But now as an adult looking back, like nobody would ever blame a child for being hit by their parent. But when you're a child, you do blame yourself. So working through the memory is to be like, oh, I'm going to detach that misbelief. So now when I remember it, it's less emotional. It starts to feel more like a regular memory. And now I'm not thinking, oh, I'm a bad person when I remember that because I'm able to detach that belief from it. So that's the reason to get in there and uncongeal it, because the congealed memory has all these like, terrible big emotions and wrong thoughts in it. And those are the parts that you're trying to get out. And I really want to throw it over to Iris because I feel like she would be better to round out anything I'm not saying or saying incorrectly.
Okay, then Iris and then Mary Pat. Go ahead. Iris, thank you so much, Iris.
Hi, Governor McGreevy, and hello to everyone on the panel. Dr. Zerbo is right on point. I think the biggest thing that I would add to that is it's not just to contain the trauma, but also to prevent re-traumatization. So when I have trauma and I have all of these, what they call negative cognitive schemas attached to that trauma, I believe I'm worthless. I believe that bad things are going to happen to me. I believe that I'm powerless. I then act in ways to support those beliefs. I put myself in dangerous and harmful situations because I don't recognize the danger associated with them. And what we know is trauma rewires our brains. So the things that should seem dangerous to me, like hanging out on a corner at nighttime, don't seem dangerous because there's a shootout outside of my house every other day. So while we want to take care of the trauma and the past trauma, we also want to provide the resources for our patients and address the hierarchy of needs, right? So I can't come into psychotherapy and work on my trauma when I don't know how I'm going to eat when I get home. I can't really self-actualize and work on being the best me I can be if I don't have safety in my home system, if I don't have an appropriate support system. And so to Dr. Zorbo's point again, when I'm working with patients, I'm a trauma therapist, it's a surgery, right? I'm opening them up, their mind up every time I interact with that patient. And if I don't have enough time to stitch that patient back up before they walk out, they leave my door bleeding, and then suicide happens, and then substance use happens.
I can't thank you enough because, and Dan can talk about this better than I can, but so many, and I've got to call Mary Pat because she's the first one to figure out how to raise her hand, but so many of our gals and guys think there's a monster right around the corner. And it's frustrating. There's often a lack of joy. There's often a lack of gratitude. We dig down for that gratitude about family, about life, about breath, about health, about children. But there's almost, to go to your point, there's the monsters around the corner, and then the monster then develops behind the corner.
Right.
So I love what Erin said, and now I know why Dr. Lavonis, why he's chairman, because he kicked it off to Erin. That was a great response, Erin. But I begin to understand. So there are these negative consequences of thinking, to go back to what Chris said about, your perception. I was a bad child. I wasn't loved. And then, as Iris said, then your behavior starts effectuating that quote unquote reality. Is that right?
Yes,
So
it can often reinforce
go ahead,
that
Iris.
reality. I was going to say, yes, it can often reinforce that reality, but the reality is that we haven't pulled people out of the traumatic situation, right? Like
Amen.
They're still experiencing these situations, so they are being re-traumatized.
Particularly those in prison.
That. In prison, right? You go in
All
smoking marijuana, you come out using heroin, right? So we know that these things are happening, and then they go right back home into the trauma. So I'm like, hey, let me help you, let me heal you, but let me send you home to live with the bear. So having, abuse in a household is like having a bear. Sometimes it's cute and cuddly, and the rest of the time it's biting your hands off. And so they're at a heightened state of arousal all of the time because this is how their body has adapted to the trauma that they've experienced.
That's Mary Pat. You're on mute. I'm sorry.
Sorry. God, I'm usually better than that. But thanks, first of all, for doing this today. Sounds like it's been an amazing.
No, and thank you for everything you've done. In the interest of full disclosure, I've been in basements in Newark with Mary Pat talking to women on addiction treatment with no camera, no press, just her listening to women when she was first lady and making sure there was funding available for diversion programs for addiction treatment, particularly for women. So Mary Pat, thank you.
Well, thanks for having me. And this is definitely an area that I have a lot of interest in. I actually serve on the board of Orexo Pharmaceuticals, which is a company that actually produces Subzol. So there's a lot of aspects about what you're doing today that I'm quite interested in. And look, I'm not a doctor, I'm not a specialist in this area, but my goal when I was First Lady, and continues to be my goal, was to really reduce the stigmatism of whether it's drug addiction or the folks that are incarcerated. when somebody asked me what my initiative as First Lady was going to be, I said, oh, I really want to focus on reentry programs. Well, my husband's staff about had a heart attack because they're like, that's way too intense. You should be building gardens for people to do, which I think that it really inspired the community that cares about reentry. But my goal was just to listen to people and to highlight the issues. And I think as First Lady, I was really successful in trying to just encourage people that, the people that you all help on a daily basis. And to me, reducing the stigmatism allows what you all were talking about, bringing out the trauma and confronting the trauma. I think when I spent time at the Center for Great Expectations, they're really focused on the trauma that these women go through. At Integrity House, you guys have done a great job about focusing on that. And I really have come to believe the way you've spoken about today that, getting to the root trauma is the first part of healing. But that's an unprofessional view, for sure.
No, and I think that's, and Mayor Pat, thank you, because ultimately it's the collective wisdom of people on this call being translated to political change, and then giving people like Dan Lombardo and myself, to a lesser degree, the opportunity to effectuate that change. But I just, if I could jump over to the great Gloria Bachmann, who is indefatigable about this space and about women and about trauma. So Gloria, we hear from Chris, and I emailed her last night. I said, you got to kick this off. And Dr. Lavona is talking about symptoms and talking about digging deeper, and Erin talking about why that's important, and Iris talking about, or Erin talking about triggering, and Mary Pat talking about, addiction. So all of that being said, whether, and particularly for our women and our men, the reality of prison is what it is. Is there a rational way to reduce trauma in prison? And I know that's a hard question.
I'm going to start with 2 points that are really important that I'd like to express. And the first is, we do have women's health preventive services templates of care, but they really don't apply to our incarcerated individuals, including incarcerated women, because as we're talking about now, the trauma, the issues of incarceration are so unique. And so under Governor Jim McGreevey, the Health Committee is working on developing a template for preventive health services for women who are incarcerated, which do focus on addiction, they focus on trauma. And I think that's the first way that we can really make a huge difference by saying preventive health services are great, but there are subsets of women who need additional services. The second point,
and if I can just shout out to you and to Chris and also we're going Monmouth and Akash and Hackett. It's these circles of concern where women are tackling questions. They're coming home, whether it's OBGYN, it's reproductive health, it's families and whatever. So I just want to shout that out. So I just appreciate you providing a support to women. And your second point?
I think the second point is one that I have to give kudos to Jim, the Journal of Women's Health and Criminal Justice. As we heard, that many incarcerated individuals don't have a voice, or the community, as Governor Chris Christie said, as Reverend Sharpton said, that there's stigmatization, that people have a lock-away mentality. And so what we're doing through this journal is we're inviting everyone, incarcerated women, women reentry, all individuals, including all of us on this call, to contribute. And some of the poems that I have read so far from women who have been incarcerated truly are inspirational. And one of them, I was actually crying. It was just so passionate and beautiful. And I feel that writing can heal and inspire in some ways. I mean, it's not the total picture, but that's another one of the initiatives that I'm really proud to be collaborating with this entire team who's on the call right now, and all the other team members with the leadership of Jim McGreevey. So those are two ways. And I think I'll just answer that real quickly. One small aspect, and that is mother baby units for our women who give birth in prison or who are pregnant in prison, that if we can prevent separation of the mother, the individual, and I should say fathers too, because we have trans men who are parents, that if we can keep parent with baby, that's probably the biggest issue that we can tackle at this point regarding young women who have children, especially in prison.
So thank you. So it's what we do for integrated healthcare networks. It's the journaling, and I'm going to call on Ruthie talk about jobs and Sandy talk about nursing, and Akash is a great medical director. But you know, we have an elder statesman here, Dan Lombardo, and you know, he's been around since Moses with the Volunteers of America. And so Dan, you know, in a serious note, you've been doing this since time immemorial. So to go to what Mary Pat said and go to what Iris and Erin said, what do we do about trauma? And, you know, and we work really hard every day to develop systems. But to go to what Chris said on the outset of this conversation, how do we overcome that trauma and do what Dr. Lavona said, dig a little deeper? And are we doing enough?
Let's go back a little bit if we don't mind. You know, gender-specific programming for women is only 25 or 30 years old. Women used to be treated like men, and many philosophies of that still exist in prison systems, which is probably the craziest thing you could ever possibly imagine. That you take somebody who has had a life that has been revolving around trauma, and you put them into an environment which is nothing but perpetuating and expanding that trauma. And then expect them, when you discharge them from prison, to go out and sin no more. It just doesn't make any sense. There's no transitions, there's no supports. And we shouldn't fall prey either to the idea of trying to do treatment programs inside the prison. It's not a pro-social environment. It's impossible for you to do the kinds of treatment and programming that are necessary in a prison to make a person successful. You have too many other elements and too many other forces in the subculture, which will not support that, will encourage it, will belittle it, will do so many other kinds of things. There was a point brought up not too very long ago about keeping moms and women together. If we have one of our women coming to our female program, and that person happens to be pregnant, their return to custody to have that baby makes absolutely no sense. When a long time ago in a galaxy far, far away, when I was in Texas, we created a program called MINT, which meant mothers and infants together. And what we did is we had them in a halfway house. And the interesting thing is it was a dual halfway house. On one side of the halfway house were the women, when the moms and the babies. On the other half, there were males. And it's amazing how moms and babies change an entire atmosphere of a halfway house. It was really something to behold. It was quieter, they were supportive. And it also gave dads a chance to spend some time with moms too. So dads and moms could bond with the baby that they had. And it's interesting then when we went back to court, after mom had the baby and she was with us for 9, 10, 12 months, and we would go back to court, we had a chance to get the sentences reduced as a result of the progress that she's made within the system itself, within the halfway house. But those kinds of things do not exist in New Jersey. And those are the kinds of things that we should be looking for. The creative, different kinds of approaches that are non-institutional in nature. My hunch is, given some of the folks that we've dealt with over the years, that most of the people that are in prison do not belong there. And let's just make that as a rational structure for designing programs that should be more community-based.
So Dan, you're the best. So Dan, what do you do about trauma? And I heard what you said about behind the wall and grappling with it. So candidly, are you just saying it's a fool's errand and we should wait? Either we should provide alternatives to incarceration, such as halfway houses. I mean, is it? So I'm saying that the reality is when we have 13,000 or 12,000 plus incarcerated persons. as to behind the wall, do we not try to address trauma behind the wall? And then I'm going to ask you outside of the wall.
I think it's a little bit more challenging in the structure of the prison system as it's designed. I think it's difficult to build trust, to build those kinds of things that are necessary in order to let your guard down. For us, when folks come to us into the community, it's a time just to make sure that they feel safe, that they feel comfortable with the environment, that they get to know the people that they're sharing a room with, that they're getting to know the staff. And so, everything that, you know about stuff like motivational interviewing, all of those kinds of skills are trained in our staff. And so that we use every opportunity to just, build trust, build relationships. So then you can start taking on some of the serious issues. And then you also have our community partners, which provide the psychiatric support that we need for folks that are seriously traumatized. And so I think that is far more effective a system. Let's divert them right from the court rather than sending them to the prison system. Let's send them to a community program instead. We can do it. It would make a bunch of sense, and it's something that would be very simple to implement.
Yeah, no, I'm going to come back and talk about housing and alternatives in a second, because I hate to say it, you're probably one of the state experts. It's hard to keep saying nice things about Dan Lombardo on Holy Week. But Sandy, could you just talk a little bit about what you do in terms of nursing and what you do in terms of nursing and trauma? And I just want to say thank you to your program, because you're in all of our sites helping our women and men access insurance. So can you just talk about what you see day in and day out in terms of accessing healthcare and how people have accessed healthcare? How can they access the necessary psychiatric and psychological support to address this trauma?
Absolutely. Thank you so much, Governor McGreevy, just for having this opportunity. And I'm really grateful to be able to speak about some of the work that we're doing around healthcare insurance and enrollment. And, the fact of the matter is there's close to 700,000 New Jersey residents who are uninsured. And when we look at folks who are coming out of the prison system, it really complicates how they're able to access these resources. And so how do we bridge those gaps and leverage some of the resources that Dr. Cornell mentioned and Iris and Aaron mentioned around getting the psychological counseling and services that they need? And there are some stigmas, I think, attached to having health insurance and seeking care. There are some cultural considerations, but we also see that there are disparities as it relates to private insurance versus Medicare and Medicaid. And so when we talk about bridging the gaps and eliminating some of those disparities, we do have a ways to go in ensuring that it's equitable across the board, but it's a start that we get folks insured. So I'm really excited about the work we're doing through Department of Banking Insurance and NJJ and through NJ Reentry in supporting folks who do not have insurance, who've come out of the prison system, and ensuring that they have the coverage that they need and that it's affordable. And so from the nursing perspective, I've been a nurse for the past 13 years. I'm a family nurse practitioner. And I think when you talk about trauma, I don't think there's a nurse that in any specialty that doesn't come across a patient that's experienced some level of trauma, from labor and delivery, from patients who've had to have surgery, to geriatric patients who may have, had a fall. So I think it's really important to include the voice of the nurse in these conversations, and having nurses who are trained or who are able to kind of speak to some of the needs of folks in whatever areas, if it's in the prison system, if it's in some of these halfway houses. So I think, it's important to have the voice of the nurse throughout the continuum.
And could you just, I see Dr. Bachmann and Dr. Zerbo shaking their heads, yes, but it's also, Sandy, what you do and in terms of registering our persons for NJ Family Care and the Affordable Care Act and getting them enrolled, whatever insurance program, so that they can access these services appropriately as opposed through the emergency department.
Yeah, absolutely. I think that we saw with COVID, and COVID just is one example that shed some light around not having insurance, not having access to primary care services, and coming into the emergency room and seeking care at the end, at the last minute that is really problematic for folks. So having folks have insurance, educating them on why insurance is important, doing that primary prevention, health promotion and screening, so that when we manage chronic diseases more effectively, we don't get to a point where because of some of the tertiary things that we see happen with diabetes and heart disease, having some of those mismanagement, it doesn't cause patients to be in a worse position when we're dealing with COVID or other chronic diseases. So I think it's really important that we address it at the onset. It's okay to go to the doctors. It's okay to get a regular checkup. My family's from the Caribbean and my dad is real old school. And like, if it ain't broke, don't fix it. So if he doesn't feel anything, he doesn't see the need to go to the doctor. But it's so important that, we kind of break down some of those cultural barriers as well. Cultural and linguistic.
No, great. I'm going to call Dr. Shah last. Ruthie, thank you to Governor Byrne. And Ruthie, you've been on our panel with Michelle Sekirker and NJBIA and working with the Chamber of Commerce to bring people back to work. And I think the old school method of reentry was getting somebody employment before addressing their healthcare needs, whether it's their depression, their anxiety, their addiction, their hepatitis, their HIV, their diabetes. And so what we're trying to do, and I look at Chris and Gloria and Petros and Sandy and I, is making sure that people are stabilized, both in terms of medically and in terms of mental health and addiction first, and then reaching out to the business community. Are we doing a good enough job working with the business community to advocate and to demonstrate the employability of our participants?
That is a good question. However, I think what we're, and I'll get to that, but I think where we're not doing a good job is where I come from. I had no idea what was going on, none. I had no idea what prisoners went through. I had no idea the kind of life they led. And of course, Jim, as everybody has said all day since 9 o'clock this morning, Jim dragged me into it, which is great. Okay, fine. And you don't say no to him. But I have never been in a conversation at dinner where anybody has ever talked about prisoners, ever. And I think that until we raise awareness, we're not going to get success in the business community. People do not know what's going on. People have no idea what goes on in prisons, never mind what women face, which has opened my eyes in a horrible, horrible way. And by the way, I do have a question for some of our panelists. Earlier, the women who'd been in prison said they would not want to keep a child. I'm not talking about halfway houses in prison because of the violence. But then I just heard now they should be. So somebody will have to answer that question for me because I don't know. But to get back to the business community, unless we have awareness, unless people know what's going on, unless they know that, hey, these people are trained and ready to come and, hey, I got to do my part too. And besides, I'm going to get a very good worker because this poor person is so trying to prove himself or herself. I can do it. I can get back into society. I can make a living. I can pay my taxes. I want to pay my taxes. I want to be a good person. I want to be a good community member. And hello, I want to vote. Right. And that's very important because when I vote, and hello, I used to be the president of the League of Women Voters, so full disclosure here, but
that wasn't obvious.
Clearly not, right? But
I prefer eating before voting, but that's just me.
Well, that's all of us, but that's a good. But after you eat, then you vote, right? But if I can vote, then I am a member of society. I can contribute. And thank you very much. I can vote that guy out who didn't help me. So I think that's my 2 cents.
No, so that's a very important 2 cents in terms of awareness, in terms of the discussion. And that's why with Governor Christie and Reverend Al and Van Jones is talking about making this, if you will, a moral crusade, a moral issue, and keeping the focus in from the first question to Dr. Lavonis through all these threads. I want to take it back to Akash, who is our medical director, a really smart guy. His SAT points were at least 150 higher than mine. Harvard Medical School, Oxford, yada, yada, yada. He's up there with Purnell in the fancy zone. I just, so Akash, you look at all of our participants, 11,000, and to go back to what Dan said, you look at the trauma in their lives and talk about the difficulty of sustaining or surviving prison. And what we're doing with biopsychosocials, what we're doing referring people to FQHCs, to the CCBHCs, to people like Zerbo, people like Pestone, people like Bachmann and Purnell. Are we doing enough?
I think there's so much more that we can be doing. And I want to go back to an insight that you, that Iris, that Dan, that so many others shared, right? You asked the question, is it a fool's errand to try to treat trauma within the setting? Well, going back to the insight that Iris shared, right? She made very clear that as a trauma therapist, what she does is akin to doing surgery on patients. And if we take that to be true, then we've got to ask the question, Governor, would we ever ask someone to do surgery inside of a prison cell? Absolutely not, right? We want them to do it in an operating room, in a hospital, in the appropriate clinical setting. And so, I think if we are serious about that, if we are serious about treating trauma, then we have to start reimagining our Department of Corrections as a Department of Rehabilitation. And there's real tangible programming that would make that possible. The nerd in me would be happy to sort of elaborate on that, but let me say, look.
But so Dan Lombardo, can I just push back? Dan Lombardo, Dan has been around since, Nehemiah says, forget it. It can't be done. The system, the structure, the culture, the environment. So what do you say to that, Akash?
Yeah, so I think it absolutely can be done. And if I heard Dan right, it sounds like there are good programs like MINT, like community-based programming that can make this happen. I'd say that, Governor, as you and I have spoken about under the leadership of Dan Hayfitz, there are models like rehabilitative release and rehabilitative housing, which instead of keeping folks who have spent more years, more decades inside of a prison cell than outside of one, instead of keeping them there for any more years, much less decades, we move them into a therapeutic community where they receive, to lift your phrase, the rituals, the rhythms, the routines needed to work through the trauma they've experienced and live a more purposeful life. And so I think there are real tangible programs that can do this. And don't get me wrong, I don't think that doesn't mean we try to treat trauma in the here and now, right? I think if there's work to be done, you do it. And so if there's trauma to be treated behind the wall, we do it. If there's trauma to be treated upon reentry, we do it. And if there's trauma to be prevented among those who have yet to go into the system as it currently exists, then it's well worth putting in place those tangible programs like MINT, like rehabilitative housing, like rehabilitative release, that would allow us to do the work for them too.
So I'm just gonna, we're coming to close. I'm just gonna ask everybody there, I always dream of, God bless Robert Kennedy, why not? I mean, I don't understand why we don't have housing with apartments where people are living like you heard Craig Haney talk about Norway, we talk about different countries. Why do we have this model? I mean, I'll start off with Chris Purnell that, Chris, if we could do anything, and I heard, and I really appreciate it, Dan is always the arbiter for me, but I mean, it's tough to do it in prisons. And to go to Iris's point is people do see that monster. So Chris, to grapple with the trauma, to go to Dr. Lavonis's original point, not just the symptoms, but to dig deeper, to do what Erin and Iris said. What is it that we should be doing with New Jersey Department of Corrections?
So if I could, let me back us up because there were some really salient things that I'd like to thread a needle through, and I'll defer to others on the panel to talk about. I'm a preventive medicine physician, so I'm looking to prevent. And there are two opportunities for prevention. And when we talk about prevention, we have to talk about prevention at the societal, at the community, and at the population level, as well as the individual. What are we doing in those neighborhoods? What are we doing around dismantling doing in disrupting those systemic forces and factors like racism, like environmental racism? Where is our obligation to achieve justice in addition to equity? And if I could borrow from another crisis, if I could borrow from the COVID-19 pandemic and what it has taught us, for so many of us who focus and work around health equity, health justice, racial equity, and racial justice, we for so long had been speaking numbers without souls, and we weren't garnering the attention or the collective political, moral, social, and cultural will to make a difference and to change how we intervene. And I really do believe we are at the right to ship moment in our nation around understanding what needs to be done in order to achieve health equity and health justice. So borrowing that from the COVID-19 pandemic, when I can have very fulsome, very transparent conversations about how forces like racism have contributed to worse outcomes in Black and brown groups, we need to likewise understand why people are predisposed to incarceration. And what are we doing about those structural, societal, social factors? What are we doing to prevent that? And then on the outside, what are we doing around reentry? And if I go back in the middle, what are we doing to really rehabilitate? I think we only think through the lens of what's possible by what has been done. Or we too often think through the lens of what's possible by what has been done. And I would challenge all systems, the systems that we sit in. I sit in healthcare delivery, I sit in public health. So challenging our understanding of what our role is, challenging the premise of what truly is meant by a health in all policies approach, because even if you are not in the Department of Corrections, what are you doing about those other conditions that I just outlined? And if I could, I would just throw that on the lap of my panelists to help close out this discussion, because that's really what I want to get us. I want to get us as far upstream and then in a virtuous cycle instead of a vicious cycle.
Amen. Thanks, Chris. That was helpful. No, and it's just, I mean, that's such an important conversation. And I'm just so grateful for your work with Essex County Corrections. Gloria, any thoughts?
Well, I'd like to bring up a point that hasn't been addressed, and that is pet therapy, that really can be soothing and calming to many, especially in a traumatic situation. I'm not saying it's the answer, but it certainly, I believe, would be an addition that would be welcomed by 90%, to have somebody that you could cuddle with, talk to, pet, etc.
It's actually one of the few, we're going to watch, Edna Mahan actually does that with the German Shepherds, with the guild for the blind. And so, but your point's really well taken.
I'm wondering if they could stay there and live as well in the setting, in the incarceration setting, the prison setting.
Permanently.
Yeah.
And then we talked about, Van talked about therapy and meditation. So Erin, trauma, corrections, reentry?
So my answer is going to honestly be that we need to tax people who are wealthy and then use the money to do all these programs we're talking about. Because I just, we all get into, and Dan's laughing, but we know
crazy Democrats.
No, but I'm just so sick of being told there's no money when we're the richest country in the history of the world. It's just enough is enough. We all get together. We all know that this is what's needed. And we're always told there's no money. And there is no money for poor people, but the money is there. So
the money's there for corrections. The money's there for prisons. I can't tell you how many times I've testified for, job training, college, and whatever. And thankfully, the legislators that were on the call before were all supportive. But Dan knows this. I'm like, guys, if we were building another prison, we'd all be hitting green lights, myself included. But now we're trying to talk about changing this system. But thanks, Erin. Iris? Oh, Iris has their hand up again. Thank you.
Oh, I think that was up from earlier. But first, I would just like to say, if we're talking about the way that we have taken care of the opioid epidemic versus how we've taken care of the crack epidemic, we can see that we can begin to address an epidemic very well, very quickly. We can provide the necessary support. We can stop incarcerating people for substance use and start attacking the social determinants of health, right? We can begin to dismantle systemic racism, and we can address things before we have millions and millions of people incarcerated and tons of intergenerational trauma that's now happening, right? When we pull families apart, we pull mothers and fathers out of the home, we put children in foster care systems, and we basically destroy the family system, we are going to see these ripple effects. And if we stop actually incarcerating people for things that they don't actually need to be incarcerated for, we can begin to address these issues. As we continue to incarcerate adolescents, we're going to see this problem just perpetuate generation after generation. So I think it has to be a two-pronged approach. We have to take care of the people who have been incarcerated and have been traumatized, and then we need to stop incarcerating people. And
then I'd also make the argument that the crack cocaine epidemic were communities of color, and it wasn't until the opioid epidemic impacted the majority community that everybody went from just say no and to, you know, treatment and truth and light and whatever. So I mean, I think we need to do a little reality check that who is impacted or who is afflicted tragically has a impact on our quote unquote solution. Kash?
Yeah, I think there are programs that exist, and to the question around funding, right? I simply can't accept the answer that we can't afford to implement these programs, because we live in a state where the per person per year cost of incarceration is over $60,000. We live in a state where the per person per year cost of incarcerating a juvenile is over $300,000, right? So to me, it all goes back to this idea that budgets are moral documents, right? Hence this idea that you don't need to tell me your values. Just show me your budget and I'll tell you your values and the precise extent to which you value them. And so if we are serious about valuing these reforms and a system of rehabilitation over a system of corrections, whatever that may mean, I still don't understand it. But if we are serious about that, then we've got to restructure our budgets in ways that reflect those values.
Dan and then Mary Pat.
You know, the thing that really bothers
By the way,
me,
I could be talking to Miss USA now instead of Dan Lombardo. So
you could be, yeah, you could be. Thank you. So the thing that bothers me is where our priorities are. If you take a look at the budget, the Department of Corrections spends more in overtime than they do in community corrections programs.
Can you give the number for this past year, Dan?
Yes, it's down to 43 million. And the overtime budget's 58 million. It's not a bad gig, you know, it really isn't. To me, you want systemic change, you have to start with the philosophy of the department, what you want to do with it, and then realize that you're going to run right into a union. And the union has some clout, it has some money, and it has some lobbying capability. And I think that's the reality of dealing with the Department of Corrections. For example, for the people that we serve, the ignominy of having to go back to the Department of Corrections to get medical care when I'm sitting in Camden and I have 3 hospitals within spitting distance of a halfway house is ridiculous. It's absolutely ridiculous. Not only that, the people who are in our programs do not want to go. They would rather have appendages falling off before they go back to the Department of Corrections. So that says more about the system itself than anything else. The system has no logic put to it right now. And it does need a thorough analysis, and the analysis has to be done on the basis of cost. He's right. I think Mr. Shah is right. It's about $60,000 a year to incarcerate somebody. A halfway house bed is $22,500.
But it's also about being, Dan, it's also about being patient-centered, I would argue. It's also about recognizing that the persons that are both in prison and coming out are patients. And the same way, to go to your point, is why, if you're in a VOA halfway house, should you go back to DOC? Why aren't you going to Cooper?
Yeah, exactly.
So thank you. And Mary Pat?
Sure. I'll just say that, I think that my husband spoke earlier about the.
He was tremendous.
Yeah, good, good. But I think when he made drug court mandatory in all counties in New Jersey, I think, that was a great example of a win-win where people got better treatment, better recovery, and it saved us a lot of money. And I concur.
And that was controversial because, I mean,
Very
Governor Chris said everybody's going to drug court and people were like,
you can't mandate this, you can't force people, but we all know about addictions. And look, I think that particularly because he is a Republican, I think that as Republicans we can speak in a different way and actually sometimes get more attention. And I'll just concur with the folks on the line. I mean, the budget from the time that Chris was governor to now 3 years later, our budget in the state of New Jersey went from 33 odd billion to 44 billion. You mean to tell me in that $10 billion increase in Governor Murphy's budget, he couldn't find more money for recovery programs and reentry programs? It's an absolute shame. And that's someone that's not political saying that. So I just would concur with the folks on the line that we have a lot of money and we should be using it more wisely.
So and Mary Pat, thank you. And Sandy?
Yeah, I would like to by saying, when we look at the mental illness.
San, your voice is, I'm sorry.
Oh, can you hear me?
Yeah, it's all garbled.
If you can't hear me,
all right, Ruthie.
I would say, based on what I'm hearing, that we tolerate a lot of very bad behavior on the part of the Department of Corrections, and we haven't come down forcefully on that yet. My husband's brother, Frank, was a physician, and he was a physician and I think you know this, Jim, he was a physician in the prison system. And he said the only difference between the inmates and the guards were who had the keys. So, and that's a long time ago. And it sounds to me, just listening and reading the press in these days, that has not changed. And unless that changes, we're going to have all of these systemic abuses. My 2 cents.
All right, Ruthie, thank you. And Dr. Lavonis, Petros, trauma and prisons, and going back to what Dan said, and I do, I do think we've made progress, and I appreciate what Mary Pat said, but I think we are getting on the right track and we're moving. But the question is I think, to go back to what Dan Lombardo said and Akash said, is how do we transform the system? Instead of incrementally, how do we make that large change? That I think everybody, in fairness, in terms of whether it's the governor's office, the Senate president, the speaker, wants to get there, but it has to there has to be a systemic change that's so critically important. Dan talked about what we used to do with women and children. How do we as a culture, Petros, and not just talking about addiction and trauma, but you're a smart guy, despite the fact you went to Stanford. But what do you think we do as a culture, as a society?
Well, I was going to bring it to the smallest possible level, and that is the dyad of the person, herself or himself, and the person next to them. And I wanted to focus on the correctional officers. We haven't talked at all about that. It's of course, all these programs that we discussed about are all very valid, and they will be wonderful to implement them. But at the end of the day, somebody lives with somebody else, and the attitudes and the warmth or the lack of warmth and the humanity that one person exhibits for another is so paramount if we're going to address trauma, if we're going to address mental health, if we're going to address addiction. So Eddie Zerbo and I went to the Department of Corrections, and we trained hundreds of correctional officers. I mean, it was a beginning of an effort, but unless you address both as Ruth just said, both the guard and the prisoner, I think you're not going to go very far. And to answer your question, Jim, about the issue of more of a cultural understanding and a cultural appreciation, going back to these very basic blocks of humanism, of interpersonal warmth, of respect, of appreciation of one another. These are the things that sometimes we forget.
Yeah, and I also heard, I mean, to be mindful of the correction officers. I mean, it's a difficult, in many cases, it's difficult responsibility, but it was interesting to listen to Professor Haney, who talked about Stanford students by a flip of a coin. So part of it is also the responsibilities that we're assigned to, the expectations, and the narrative, how we understand ourselves. And I would just, I mean, I was had a pleasure of being on the phone the other day with my friend Liz from the Bergen County Prosecutor's Office. And Liz was talking about what police officers do now in terms of addiction treatment and psychiatric. But part of that is setting, I think Van said this best, setting expectations and longitudinal objectives against which we'll measure our success or failure. And part of that has to do with changing the narrative of how we understand what it is that we do. So I just, to everybody on this panel, I just wanted to say thank you. It congealed wonderfully, and I'm really grateful, because the question of trauma, I wanted to understand more fully, and I think we began to do that what we do with trauma, and I appreciate Erin and Petros and Iris and Gloria and Chris, and what Akash drives us, God willing, as our medical director every day to do, and to Sandy and to Mary Pat and to Ruthie, from the perspective of community leadership, governmental leadership. How do we begin to shift this to a different system? I would respectfully think that the system we want is more aligned with what Dan's vision is than what we have today. And so, God willing, it's what goes back to what Van said about that child with the bird in his hand. You know, pastor, is the bird alive or dead? And the pastor said, it's in your hands. So if we believe in a vibrant democracy, it's in our hands, not only on the governmental level, but on trauma and treatment and how we do that. And so with that, I want to say thank you to all of our great panel.